So the next speaker is Dr. Andrew Reynolds. You all know already very well. He's a co-director of the Edgar Diabetes Research and key researcher fellow at the University of Kentucky. And Andrew has been conducting and contributing to several systematic reviews and meta-analysis and been very essential for the finalizing of our guidelines of the 30 years. So really looking forward to Andrew. Is DiRECT the most promising lifestyle machine diabetes management?
Okay, let's have some fun. Thank you very much also for the invitation, and thank you for Jess for the introduction there. So I'm going to assume, I think all of us were here 2 days ago at the open plenary session in DiRECT. Actually, technically, Mike wasn't here for that first 10 minutes, but he did get here in the end. And this is really great for me because I don't actually have to spend slides in talking to you about DiRECT being a total diet replacement period, followed by food reintroduction, and then a longer period of weight loss support. I don't need to talk to you through the first trial and the results there and the remission rates because that's already been done. I can actually chop and change, move my talk a little bit and talk about what I think is important and what's going on with DiRECT. So this is great for me. So we have a principal investigator in the audience. Why isn't he talking about this? Well, I'm starting to get some experience with DiRECT trials. I'm thinking about aspects of DiRECT and how it's going to fit into ongoing clinical care. Efficacy, effectiveness, implementation, continual improvement assessments. It's really fascinating to see how DiRECT is moving along a pathway at different rates in different parts of the world. But it's a very cool sort of topic to be involved in at the moment. So I can say while I'm working with DiRECT, I have no financial or commercial interests or relationships with any company that would gain with greater uptake of DiRECT. So that's my disclosure. And from that, I have no conflicts of interest here. So what are we talking about? We're talking about the goal of diabetes management is to achieve remission. We can do that with bariatric surgery, GLP-1 RA use, or dual agonists, and we can do that with DiRECT. That's what's been shown. The point of this talk isn't to compare DiRECT with bariatrics or compare DiRECT with GLP-1 RA use or pharmacological agents. They're actually all useful tools in an anti-obesity toolbox. The more relevant research questions in this area are, well, what works for whom? How do we work with them in combinations? And how do we deliver them equitably? So I've come up with some research questions following Mike's talk that really grounded us on what DiRECT was. That I wanted to talk about. And the first one is, well, what are the guidelines say about DiRECT in diabetes management? Is it something that is actively promoted? Is it too new? Is it coming in? So let's have a look. Mike called this quite an old talk 2 days ago, an old paper. It's been less than 3 years since it was published. We did it to inform our DNSG guidelines. And what we wanted to do was evaluate dietary approaches for weight loss and remission in people with type 2 to inform those DNSG guidelines. We considered a wide range of potential approaches, such as low carbohydrate diets or Mediterranean, high protein, very low energy, formula replacement, high MUFA. And really what we found is we knew already that weight reduction is fundamental for type 2 management and remission, but we wanted to know which dietary approaches could be recommended or should be recommended to achieve weight loss. Overall, we found that the programs with a total diet replacement induction period were the most effective for remission. But then really in the discussion, we had a little bit more chance to talk about nuance, and I really love some of the thoughts there. The skills and empathy of practitioners may overcome any dietary specific effects on weight loss by providing consistent evidence-based support. So that passion, that accountability of a health professional is very important. And that moving away from basic RCT trials of treatment A versus no treatment or treatment B, more realistic trials are required in which individuals are offered choices. So that informed the DNSG recommendations. I think they came out last year. And what we said in our weight loss section is that people with diabetes who have overweight and obesity should have evidence-based treatments. That remission is possible through sustained weight loss. That nutritionally complete low-energy formula product can be used either temporarily for weight loss induction and as total or partial dietary replacement. And really a low-energy total diet replacement program provided by a trained health professional. It's recommended to provide sufficient weight loss to induce remission. And following that weight loss, long-term, low-intensity support for weight loss maintenance is recommended. So that is the DiRECT approach. So really nice and clear. But we didn't stop there. The evidence continues. This was published just 3 months ago from John's group, and really good to see they considered the role of meal replacements in pre-diabetes or people aspects of the metabolic syndrome. And again, they found a nice, consistent result, concluding that incorporating meal replacements into weight loss interventions led to important reductions when compared with conventional food-based weight loss diets. So that was excellent to see come out. What does the ADA say about total meal replacement and DiRECT? They don't talk a lot directly about DiRECT. They update their guidelines every year. And this year, they did say studies have demonstrated a variety of eating plans can be successful, and this includes meal replacements. They say that no single approach is superior and we need more evidence. But partial meal replacement or total meal replacement is an additional tool or strategy for energy restriction. 100% makes good sense. They talk about what meal replacements are, and they show that they've been effective for a range of things. And they sort of conclude that partial or total meal replacements can be potential short-term strategies for weight loss. So they didn't really take it further into the supported weight loss maintenance phase, but they're talking about it and they recognize the benefits, which is great. So concluding in regards to guidelines, DiRECT type approaches, including total meal replacement, food reintroduction, and a longer period of supported weight loss maintenance, are now recognized and considered effective. The next question I wanted to ask is, what about long-term effects? And I guess I want to say this because 2 weeks ago I was talking with an endocrinologist at home, and they said, oh, I wasn't that impressed by the 5-year results. I don't think I'll use DiRECT much anymore. I was like, eh? And I had to go back and I looked at the paper and I was like, well, what are they thinking? And I guess what they're actually thinking is they're thinking about this as a 5-year trial where everything is controlled and separated, and by the end of the 5-year, the confidence intervals interlapse, I think. And it took me a while to figure that out, and I think that's where they went. So I went back and had a chat, and I said, well, actually, it was more like a 2-year intervention. And then that 2-year, every participant got a letter, including the control group, with a scrawly little signature at the bottom, and it said how good DiRECT was, how useful it was. It was such a landmark study. Here are the benefits of achieving. So is that really a control group anymore? It's contaminated, isn't it? That control group at 2 years had higher body weight, had higher poorer blood glucose control, had higher rates of type 2, and therefore they were more likely to receive treatments such as DiRECT or GLP-1 use or more intensive healthcare support. So it's a contamination for control group. It's not a 5-year RCT. It can't be really considered in that way. What we can say is that some people might consider we have long-term evidence, but we also don't have long-term evidence for GLP-1 use, do we? We don't have it for vaping because it hasn't been around for so long, and we don't have it for the effects of microplastics. We don't have long-term evidence, but we're still talking about them and we're still acting on them. What we really do clearly see is that there's an over 6 kg weight loss in the DiRECT trial at 5 years, and that's after initial weight loss of 12 kg. So all that time, those people were not experiencing the micro and macrovascular damage. They were not progressing along towards diabetes complications. This is a very clear benefit. So I'm going to keep talking about endocrinologists, but I imagine that maybe if she was thinking that, other people are thinking that as well too. So it's really clear to understand what data are we now looking at and what are we talking about. The next research question, well, what aspects of these DiRECT type programs that appear crucial? And the first one is, does it have to be meal replacement? Might be showed a Scottish study and a Nepalese study with the Dalbat that used food. But if you look at the effects of the meal replacement ones, it's pretty consistently impressive. This is weight loss at 3 months, so following that total diet replacement period. The 2 studies with the yellow dots were single arm, so they're not included in the combined effect. But really all I want to show is that, wow, look at these great benefits. There's different control arms at play and there's different population groups being shown here, but it's pretty consistent, isn't it? So it's effective. Do people adhere to it? Yeah, I think so. This is time for a year on the x-axis, and it's the average number of day of the meal replacements in blue, or meals in black. And what we saw is for total diet replacement, they were advised to have 4, and they're having 3 to 3.5 a day, and less than 1 meal or 1 meal a day. In that first 12 weeks, then they cross over with the food reintroduction phase, and then throughout the rest of the year, they're having 2.5 to 3 meals a day, and half to none. So they're adherent to it. They're reporting that they're actually having these meal replacements. And then what did they actually think about it? Why don't we ask patients that question? The only thing I really need to tell you about this trial is that it was done in a single primary care provider that was in a very high social deprivation neighborhood, and their clientele were Indigenous, ethnic minorities, low income, and refugees. So those are the perspectives that we were trying to obtain and understand. What they thought about that first 3 months of total diet replacement was that it was initially challenging. The first person said those first 3 days were incredibly challenging. I had no energy whatsoever, but after that, the more I got into it, the more I felt I could stick to it. Most people sort of said, oh, day 5, day 6, really hard. And then surprisingly, within that first week, or at the end of that first week, they seemed to sustain it. It wasn't hard as I expected. I like things that are prescriptive. You've got a plan. I understand that person. That's a direct person. Yeah. Once you get used to it, it was pretty easy. I don't understand that person. They said it was pretty easy. Total diet replacement, stopping all that social engagement. I thought it was pretty easy. Amazing. And all I had to do was pick the next one. So the simplicity there is that these people aren't going to the grocery supermarket to shop. They're not preparing meals and they're not having to clean up afterwards. They're not really thinking, what should I cook tonight? They're using a little sachet with some hot water or some cold water, and they're moving on. So really this change in that focus on food was fascinating, and I think it really helped them adhere to that request to have total diet replacement. They found that the fast results and the weight loss in that first 3 months was really motivating. You've got a plan and you see results quickly. Those results motivate you to keep going. I got more motivated as time went on because you're starting to see small changes and people are starting to comment on small changes. So that observation of fast weight loss is a motivator. Everyone found food reintroduction hard. This was true in the qualitative assessment of the initial DiRECT for the participants and for the staff that delivered it. And we found the same thing. It was hard for everyone. A lot of it was about portion sizing. So that second one, when you come off total diet replacement, that kind of restriction has disappeared. Then it becomes a big battle or a bit of a battle with portion sizing. I know that you can put it on faster than you can take it off. Food reintroduction made me nervous because I felt like I tried really hard to get the weight off and I didn't want it to come straight back on. So people were really worried about that lack of control and suddenly returning to maybe the bad or old habits that they initially had. And then at 12 months, what did they think about the ongoing support? Well, they thought it was very important. It's just having those regular check-ins that kept me on track. It just gave me a little guide of where I'm at. It's got to be a long-term rest of your life sort of regime. One of the key questions that I asked them as well was, does it have to be dietitian delivered? Because I was thinking about the cost effectiveness of delivering it. Dietitians can be more expensive than health coaches. Did that need to be a dietitian? And then why they recognized the support of the dietitian was the biggest enabler for their weight loss. I still questioned, is it actually the dietitian, or was it just that ongoing support and access to a trained health professional that is critical? The dietitian themselves thought, oh no, maybe it didn't have to be a dietitian, but there needed to be a dietitian to structure for sort of complex case management or to be referred to. And certainly in the initial DiRECT, it wasn't all dietitians. Mike seems to stress that incidentally, they could have been dietitians, but that wasn't the benefit. It was the training and the fact that they were there, that were supporting, and that consistently checking in, that was effective. And then just real quickly to finish off the participant experiences and perspectives is that they were really reporting quite broad benefits. I feel good about my body. Yeah, I feel happy. I feel comfortable about my body. That person had type 2 diabetes and obesity and a series of unsuccessful weight loss attempts in their past when they started the trial. 12 months later, they're showing a level of body satisfaction that not all of us here would have ourselves. So powerful stuff. Certainly seeing the results in terms of blood sugar and sleeping better, having more energy, just generally feeling better as a result of what I've been doing. Recognizing it was them that they did it, great stuff. I found myself going around the supermarket reading food labels. I used to laugh at people that did that. So that's a growth in nutrition literacy. And I think about food differently now and actually think about what I'm putting into my body instead of eating whatever's out there. So a growth in understanding of health literacy as well too. So for those successful elements of DiRECT, I really thought there's a lot going on within a DiRECT program. The initial total diet replacement is effective at producing rapid weight loss, which is motivating for people to keep going. Food reintroduction, however, is hard. and long-term low-level support is needed for that weight loss maintenance. Although in saying that, it'll be interesting to see the new trials coming out, such as the German trial, to see how it goes just with the initial weight loss phase. Last data collection next week, right? Nice. So I guess the last, or one of the last components I want to talk to is where to next with DiRECT. Personally, for me, I want to know who pays. I want this to be an equitably delivered sort of intervention, and the cost of these things can prohibit some people from joining in, and that reduces or increases inequity. Sorry. I want to know how DiRECT fits in with GLP-1 use. It's not one or the other, it's how they work in combination. If someone bows out or fails on one, should they be offered the next one? When you're using a GLP-1 and you don't have a huge appetite, you still need a nutritionally complete meal. And these sort of meal replacements relate to that and are nutritionally complete. So I don't know if we need a new industry of TV dinners that are smaller for people who are on Ozempic. I think maybe we just need to talk more about sort of DiRECT type delivery. We do need new guidelines that relate to the nutrition requirements for people on GLP-1. Maybe we don't need to talk about supplements for skin sagginess. Oh, and then I just really want to say, is the knowledge that we're gaining from DiRECT able to reduce the stigma of those assessing weight loss support? Because the knowledge that we've gained from DiRECT has sort of given us new resources and ways of talking to people. It's a lot more pragmatic. It's not about feelings of weight loss. It's actually, well, here are the outcomes that you could achieve. If you have a 10% reduction in weight loss, we can talk about prevention of type 2, or we could have remission. We could have a reduction in sleep apnea. We can talk about PCOS. It's giving us data that is very informative and very quantitative that will help us communicate people about what they want, and this is how we get there through weight loss. And then the implementation studies that are now happening. This is the diabetes prevention program in the NHS. You can see there 1.5 million referrals. I don't know how old this slide is, but over 700,000 people have started. It's not a controlled trial, it's an implementation study. We've got that for prevention, and they also have that for the pathway to remission program. What do they look like? Well, it's DiRECT, isn't it? It's a period of total diet replacement, followed by food reintroduction, weight maintenance period, and rescue packages for weight regain. So those sorts of implementation studies are fascinating. They're providing us new levels of evidence, looking at things like dose response in regard to the sessions that people attend and that need for that ongoing healthcare professional support, as well as avoiding diabetes diagnoses. So to conclude, DiRECT type approaches have come a long way from pure research findings and are now being implemented in a wide range of settings. And we're learning more and more about them as the different sorts of research designs happen. Long-term benefits from the initial RCT follow-up are obscured by contamination of the control group, but they are still there. DiRECT type approaches remain optional for patients. So patients come with their own histories and failures. However, use of these evidence-based treatments and having a wide range of implementation studies may reduce stigma about trying to obtain weight loss support in the future for people. And that's really important. Future research is not DiRECT versus GLP-1 but how to use them in combination and even who should be prescribing them. And then DiRECT is really a current and evolving example of moving research into clinical practice and the practicalities of large-scale implementation. So it's fascinating to be watching so far and to continue watching what happens next with it. Cool. Thank you very much.